Hi friends, in DAMS we have initiated a series on YouTube called as Unplugged. It's called as Medicine Unplugged, where we try to discuss a clinical scenario and we try to see the imaging and the lab perspective along with the clinical scenario. And we try to do a differential diagnosis approach. Today I have selected a case which I feel is important for people who are appearing for exams like NIMHANS, which are neurocentric, or residents in radiology, residents in neurology, and even if you're looking at central institutes. I feel this is an important topic to consider. Let's try to understand. I've tried to create a clinical vignette with a visual and we'll try to discuss the differential diagnosis. Let's see together. So we have in this patient, in this question, we have a child who is 8-year-old, presents to you with refractory seizures, epilepsy, which is refractory to treatment, and this epilepsy he had since the age of 2 and it has been like this since then, and an MRI is shown to you. So we have a pediatric age group patient and a refractory epilepsy in the history, MRI is shown to you. Let's see the picture. This is a T1 weighted MR image. So look at the hemisphere on the right side and look at the hemisphere on the left side. Do you notice the sulci, the Sylvian Fisher area, the opercular area, the sulcal area? They look more prominent on this side. Let's try to see the T2 weighted image. Now on the T2 weighted image, you can actually appreciate the stark asymmetry. You can see the CSF spaces on this side are more prominent. The cerebral volume is less. The CSF spaces are more prominent. What do you think we are looking at? Look at the size of the ventricle. Asymmetry. This side is more, this side is less. This part is showing atrophy. So you can see hemiatrophy more in the opercular area in this two images, and you can see hemiatrophy, prominent CSF spaces with a child with refractory seizures, a pediatric age group patient. Now I also want you to look at the skull. There is no calvarial changes in this patient. And a contrast enhanced MRI in this patient was also done, in which it was unremarkable. There were no abnormal enhancement seen. What is our differential diagnosis? The diagnosis to consider in such a case is Rasmussen's encephalitis. Now, to many of the graduates listening to us today, it will sound like a new word. Let me explain what is Rasmussen's encephalitis. Rasmussen, whenever we talk about encephalitis, you think of infective etiology or viral etiology. Here today there is a lot of talk being going on in the world about immune mediated encephalitis. So this is Rasmussen's encephalitis is now believed to be a immune mediated inflammatory disease of the CNS. And the key here is most of the patient here will be in the pediatric age group, just like in our patient we had a 8-year-old child, that is the classic age. You sometimes, rarely, very rarely it can be bilateral, but most of the time it is a unilateral problem. Mean age is 6 to 8 years. That goes with our age of presentation in this patient. Why does this happen? The postulated etiology is an autoimmune phenomena involving the antibodies against the glutamate receptor 3. And although when you talk about immune mediated encephalitis, there will be a role of immunotherapy. Here the immunotherapy has a poor response. The Rasmussen encephalitis shows a poor response to immunotherapy. That is why we are talking about it here in the today's discussion. Now, so what is the key word here? Why it is happening? It is the immune mediated encephalitis causing hemiatrophy of the brain. There is a progressive atrophy of half of the brain is one of the key MRI features to consider. However, when we see hemiatrophy, there can be other differential diagnoses in our mind. Can you think of some important DD here? Now, you know this by now. Sturge-Weber syndrome is one of the most important DDs to consider in whenever we talk about hemiatrophy. But then the question should have that facial nevus, that port wine stain. And when you do a contrast enhanced MRI in these patients, you will have enhancing subpyelangiomas on the brain, and enlargement of the ipsilateral choroid plexus is also seen. Okay, and this atrophy should have also that gyri-form curvilinear calcification, which we popularly called as the tram track calcification. In our patient, there was no calcification, no enhancement, no facial nevus, no enlargement of choroid plexus, which helped us to rule out Sturge-Weber syndrome. What other differential diagnosis should you consider in such a patient? There is something called as Dyck-Davidoff-Mason syndrome. Now this is because of different etiologies leading to a fetal life insult, leading to unilateral cerebral atrophy. But because this atrophy is happening in the fetal life, there is time to compensate, and there is relative hypertrophy of the calvarial and of the hypopneumatization of the sinuses. And if you notice, when I was describing the MRI, I told you there are no calvarial changes, which helps us to differentiate Dyke-Davidoff-Mason syndrome from the other two. That is how we differentiate. So we have hemiatrophy, and refractory seizures are the classic presentation, pediatric age group we think of, and progressive atrophy of the brain, half of the brain, is very typical of Rasmussen's encephalitis. Immune-mediated encephalitis is a new buzzword. Keep it in mind, especially the people aspiring to get into NIMHANS or into neurosciences, residents. It's a very, very important topic even for radiologists as well. Okay. So if you enjoy this video, I would recommend that please follow us on DAMS LE channel on YouTube and Facebook. We keep adding new interesting cases on it. If you appreciate this, please write to us in the comment section. We look forward to hearing from you. I wish you all the best.